In terms of disclosures, I hold stock options for a company called Little Otter Health, which is a telehealth company that delivers care for kids age 0 to 12. And other than that, I don't have any other disclosures. So today, we would like to cover 3 commonly used SSRIs, including what's the initial usual dose, and then what's the target dosing. We want to be able to talk about SSRI risks, including common side effects, including the risk of activation, and then be able to develop and apply language pearls in your practice for patients and families when you're discussing anticipated benefits, risks, and side effects. And so basically, serotonin reuptake inhibitors have been around for a long, long time, about a little more than 30 years, with Prozac being the first. And they all have a pretty similar mechanism of action, although they do have different enzyme pathways that they go through, and they do have some subtle differences. But they all essentially block the presynaptic serotonin reuptake, and they can be used to treat both depression and anxiety, typically with doses kind of on the lower to medium end for depression, and then sometimes higher doses are needed to really cover anxiety adequately. There are some common well-known side effects, including stomach upset, maybe feeling a little bit nauseated, maybe some diarrhea, which is usually at the very beginning of treatment. Sexual side effects are real and can happen in, depending on what you look at, between 30 or more % of patients can experience some sexual dysfunction. So it is important to be thinking about that, especially if you're using these for teenagers and young adults. You can also experience other things like anxiety, restlessness, nervousness, and then changes in energy level and dizziness. And we'll talk about that a little bit more later. Not to say that they are 100% safe, but there is very little risk of cardiotoxicity and overdose. And usually with an SSRI overdose that is intended as a suicide attempt, this is usually not life-threatening. So that's something to keep in mind, in contrast to the older tricyclic medications, which could be lethal in overdose. And it's important to be aware of different things that go along with it, including discontinuation if you stop it abruptly at a higher dose, also activation. And at too high of a dose, you can get what's called affective blunting, where you don't feel sad or anxious anymore, but you also are not able to feel joy in the same ways. And that is something important to check in about as you're titrating up, because sometimes you can, unintentionally get to too high of a dose. And then in terms of evidence for use in pediatrics, the strongest evidence is really for the SSRIs, in particular, Lexapro, Prozac, and Zoloft, and less so for SNRIs. That said, SNRIs, if you do end up getting there or somebody comes to you on one, there is less risk of activation with SNRIs than there is with SSRIs. So in terms of kind of general guidelines and things to keep in mind, the efficacy is similar. And you want to think about what has been a past response, what's the overall side effect profile, and then what are the symptoms that someone is presenting with. And then are there comorbid medical conditions that you should consider, both if they're taking medications and otherwise. And there's usually a 3 to 6 week lag time between getting to a therapeutic dose and symptom improvement. And you usually see some level of remission by week 4. That said, especially in anxiety, at times you can see a clinical initial response sooner than that 3 to 4 or 6 weeks. If you don't have an improvement at 8 weeks at an adequate dose, then you want to consider switching to another or augmenting with another agent if you're seeing some partial response, but still some ongoing symptoms. And overall, in terms of the literature, there's greater demonstrated benefit for use in pediatrics and anxiety than there is in depression, especially in younger children. And usually the younger the child, the more likely there is a risk of having side effects. So in terms of screeners, we were just putting together our HRSA reporting that is supporting our program, and was so pleased to see that the rate of usage of coming, into a CAP consultation initially, already having filled out at least one screening tool before calling for a CAP consultation actually increased from 41% initially at the start of the program to 53% in the past 9 months. And so I was just delighted to see that people are really using rating scales more. These are really helpful at both initial assessment and also symptom tracking. And so the commonly used ones, the GAD-7 is brief, 7 questions. The SCARED is a deeper dive into different types of anxiety. And then depression, I think everyone's familiar with the PHQ. And then there's also the short mood and feelings questionnaire, as well as a longer one that also gets into things like self-esteem and is validated down to age 8, as opposed to the PHQ, which is to age 12. And then a tool that can be good for both anxiety and depression assessment is the RCADS, and that one is also validated down to age 8. And so thinking about kind of what's the level of severity, you also have to use some clinical judgment in here. So this is not just a hard and fast, you have to go just by the score. You have to look at the overall presentation, but in general, when there's really 0 to minimal symptoms, you don't have to do anything. If there are mild symptoms of depression, you want to see that person back, sooner than a year from now for the next well-child check, and just repeat the scale at that time and maybe educate on some lifestyle interventions. For moderate depression, you want to do first-line therapy, which includes, things like wellness counseling, thinking about your rhythms and routines and diet, making sure that you're moving your body, making sure that you're getting adequate sleep, and then considering medication potentially if therapy is not necessarily working, or if it's impossible to access, as we know it sometimes is right now. There are long waits. And then if you get into the more moderate and severe range, you want to think about really actively engaging in therapy and still doing those first line psychoeducation interventions and lifestyle modifications, and then thinking about medication. And if it's really severe, you want to think about safety assessment as well. Similarly, for anxiety, kind of follows along a similar trajectory, but when you get into the moderate range, you can consider not only cognitive behavioral therapy, which is the most evidence-based type of therapy for anxiety specifically, but to also consider an SSRI. And these are some tools that can be useful, and we will share these slides so that you guys have access to these ongoing. But here are some self-guided CBT tools for anxiety for teens, and then for parents of younger children, and also Coping Cat, which has been around for a long, long time and is a really wonderful program and is now available online. For depression, so evidence-based treatments for major depressive disorder include cognitive behavioral therapy, which for folks who are not familiar with this is really looking at the interaction between your thoughts, your behaviors, and your feelings. It was kind of the original cognitive triad that Aaron Beck came up with over 50 years ago. And then more recently, what's also been added in is kind of physical reactions, physical sensations. Am I feeling tired, hungry, hot, things like that. And these all interact with one another and then cause people to behave in certain ways, cause people to feel certain things. And the things that are modifiable here, we can't change our feelings. Our feelings are always there, and they're going to come out in one way or another. But what we can do is modify our automatic thoughts that may be kind of overreacting to a situation. We can modify our behavior, and we can either plan ahead to prevent ourselves from feeling hungry or get more rest, or change our our physical situation so that we help our physical state. Interpersonal therapy is another evidence-based therapy, and this is really about kind of what is going on in the here and now and being able to problem solve with interpersonal problems. So when do we think about prescribing in primary care? when there's been ongoing uncomplicated anxiety that progresses and is not really responding to therapy and other interventions, when there's really significant impairment in everyday functioning, um, when there's been, a failed or a partial response to current therapy and other active supports, and really importantly, that both the parent and the patient agree. Patients need to assent and parents need to provide consent. You can give education on the medication risks and benefits. Um, Related to this, it's really important to know the patient and be able to monitor them, because if you have somebody who's going to be inconsistent with taking it, then at times that can be, more risky than not taking a medication at all, because you can have uneven blood levels. And in particular with medications with a shorter half-life, you can go through withdrawal and then you take it again and you may start to, feel some of those early side effects. And so it's just important to know that you have somebody who's going to be committed to this and willing to work with you. And then if possible, being able to consult and collaborate. And before starting, you need to provide education to the family, and then getting the consent from the guardian and the assent from the youth, and also thinking about safety planning, and then having kind of a regular schedule of visits that at the beginning will be closer together. And then usually once you get past the 3-month mark or so, then you can space it out a little bit more. But at the beginning, when you have the most concern for side effects and you're titrating to the right dose, then it's important to see people more frequently. Usually I do that 2 weeks after starting, and then 2 weeks after that, and then about every 3 weeks for the first 3 months because of the risk of activation and other side effects. What's recommended is actually seeing people once a week for the first month, but in reality, I'm not sure how many people actually adhere to that schedule, because we know that once a week is pretty hard to squeeze in, but you could also include a phone check. That's a brief one, just checking in about side effects. As I said, we're going to share these, so this is not something that you need to, memorize by any stretch, but I want to highlight here that that Prozac and Zoloft and Lexapro all come in both tablet and or capsule forms, and then also liquid forms. The liquids don't taste very good. They are not like amoxicillin where it comes in, cherry and bubblegum flavored. It is, sometimes it tastes a little sour. And so, for younger kids, just to consider that it may need to be mixed in something, but for the ones that are tablets, you can crush those and put those into other, yogurt or other things like that. And then here are some usual starting doses, and then also what the titration schedule would be. And then, kind of a typical low to medium end dose for the different ones that we use commonly. So 20 milligrams for Prozac. And then, Zoloft can be effective actually as low as 50 milligrams. And then Lexapro, the maximum dose is really 20 milligrams. The milligram per milligram is thought to be actually 2 to 4 times as strong as that of Prozac. So to keep that in mind, that it's not exactly equivalent. And then here we have the FDA approval. Importantly, Prozac is FDA approved down to age 8 for depression and down to age 12 for with Lexapro. And then it also has approval in OCD. And what's interesting is that it's not kind of uniformly approved for generalized anxiety, but that has to do with the way that the FDA assesses kind of the number needed to treat. They are all effective for anxiety. And then here is just a little bit about kind of clinical pearls to consider. And I'm sorry, this isn't displaying 100% within range. But Prozac has a very long half-life. And the nice thing about that is that if you have somebody who is, not very adherent, then this can be helpful, because even if they miss a day or two, they're not going to experience the withdrawal kind of side effects that you might with another one, that if you miss it for, usually 2 days or more, then you're going to start to feel some withdrawal. If anything, Prozac tends to be a little bit activating. It's not always true. Some people can feel tired from it, but if anything, it does tend to be a little bit more activating. And then also when you're stopping it, you don't have to taper it down. You can just stop it. Sertraline, if anything, is often a little bit sedating, and so can be better dosed at night. And I did have a patient once where they accidentally took an extra Zoloft and they actually had a dystonic reaction. It does have a mild dopamine blocking effect. And so just to be aware of that, that you can get some reactions like you might with too much Reglan or medications like that. And then Lexapro is thought to have less sexual side effects and less drug-drug interactions, certainly, along with citalopram. And this one can be either activating or sedating, depending on the person. This is cross tapering is something that I think we don't talk about quite enough. How do you switch when somebody is on a medication that's either not working or the side effects are really problematic? What you want to do is substitute. You can do it one of two ways. One is to just stop one med on day 0 and then start a new one on day 1. And I have Lexapro 10 milligrams here, and you haven't started the sertraline yet. And then here, you just stop the Lexapro outright and then start the sertraline. And a rough equivalent dose of sertraline might actually be 100 milligrams, but I usually try to go a little bit lower than what the equivalent would be, just to start off in a more conservative way. This, is written about. I honestly will say that I've had less kind of clinical success with this more abrupt switch than I have with more of a cross taper, where you gradually shift things over the course of a few weeks. So in this example, Lexapro at 10 milligrams, this should be 7.5 in the first week. And then you start sertraline at 25 milligrams. And then on week 2, you go to 5 milligrams on the Lexapro, not 10, and then go up on the sertraline to 50, and then, so on, and kind of increase by 25% on the one and go down by 25% on the other. And if you are switching with Prozac, you want to consider the half-life. That can be 4 to 6 days. And so you want to stop it for about a week and then start the new SSRI at a conservatively comparable dose. Or even just at half of that dose. Activation is something that is actually fairly common. Depending on the study that you look at, it can be anywhere from 3 to 55%. And so this is related to starting an SSRI. You are more likely to see it during the first 3 months. And in particular, the highest risk is in the first 11 days. And then the risk goes down until the 1 month mark. And then it goes down further between the 1 month and the 3 month mark. But there's still, some significant risk. And it is thought to be one or more of these kind of key symptom clusters. So increased irritability, increased akathisia, which is a sense of restlessness, and then also disinhibition and appearing more impulsive, symptoms that look like mania, and increased risk of self-harm and suicidality. And the risk does seem to be inversely related to age. In terms of assessing this TSAP profile was created, and this has been used more kind of in research studies than it has in clinical practice, but it really just assesses the severity of these symptom clusters. So what do you do when this happens? You want to assess whether they're being, adherent and taking it every day as expected, because if it's intermittent adherence, then you have much more uneven blood levels, and so you want to know what's happening with that. And then you can either just try to decrease the dose, especially if there seemed to be a beneficial response at a lower dose, and hold out at that lower dose for some time and see if it resolves. And then you can look at going up again much more gradually, a month or two down the road. You can switch to an extended release version or a different SSRI, or you can stop the medication. If you switch to a different SSRI, it may or may not happen, but that person is probably more at risk of this happening than if they'd never experienced it. And if it's just akathisia, that restlessness, but you're seeing an overall positive response, then you can treat it with a beta blocker. And so the difference between activation and bipolar switching is that bipolar switching usually is something that occurs later in treatment and may not stop with discontinuation of the medication, unlike the activation. And this is more, that you see some true manic or hypomanic symptoms. And there's often a family history and, maybe some things that would indicate it. In contrast, behavioral activation, just because you've experienced that, it doesn't mean that you're more at risk for developing bipolar disorder. I am gonna just talk about this briefly. I imagine that most folks are very familiar with the FDA black box warning, and just breaking this down, and this is how I talk about it with parents and families, is that, so I need to tell you about this black box warning that came out in 2004 when the FDA looked at 24 randomized controlled trials, some of which were published and some of which were not published because they weren't favorable for the medication, and found that there was an increased risk of suicidal thinking and also self-injurious behavior, but not actual increased risk of completed suicides in 3.8% of patients taking these meds versus 2% with placebo. And so the risk is thought to be the very highest in the first 9 days of treatment and is more likely to happen when you start at higher than usual doses. And there doesn't seem to be a significant difference between the different SSRIs. However, Prozac was the one that seemed to come out a little bit better with this. And so this is something that doesn't usually happen all of a sudden in the middle of the night when things have been, going along just fine or improving. And so I just want you to call me if you see any signs that things are getting worse. And then in terms of how long treatment should last, usually the recommendation is 6 to 12 months and a little bit longer for depression. And if you are thinking about stopping, really considering the family, what their preferences are, and then also, is it a good time in the year? Maybe not when finals are coming up or when you're about to go off to college, but let's think about it maybe, at the beginning of the summer when things are probably lower stress. And I'm going to pause there.
Great, thank you so much. So I think we have maybe 1 or 2 minutes if there's any questions that came up before then we transition to our case discussion.
I had a question on one of the tables. This is Amy Dolinar. The table, it showed all the different meds and the max doses and the target doses, and one of them had a max dose that was much lower than the target dose. I think it was Celexa, and I was just trying to figure that out.
I was looking at that too, and I think that I guess I had copied this from another table, so that was incorrect. So the max dose for Celexa is 60 milligrams, and you usually want to start with 10 milligrams as a starting dose, and then 20 milligrams can be a usual kind of adequate dose for depression and perhaps higher for anxiety.